So, good afternoon. Thanks. Aram. Dr. Raghu sir, Shiv sir, Sadashivan sir, for calling me here. So, my talk is on ultrasound for musculoskeletal pain in lung cancer. So, ultrasound make interventions very easy and safe nowadays. And I think everybody is having access to ultrasound. So, using ultrasound intervention make easy and it improve the quality of life of cancer patient. So first we discuss about the prevalence and importance of pain management in cancer patient. So pain is the major symptom a cancer patient present with. So prevalence of pain in cancer patient is around 51%, and the prevalence increase with certain type of tumors like head, neck, lung, breast cancer, and also with the staging. With advanced stage, as stages advanced, pain is pain prevalence is reached up to 66% in majority of the cases. So in the journey of the cancer, every patient some or other day present with pain and come to the palliative care clinic. If we saw in the lung cancer, so it affect around 27% of the outpatient patient come to clinic for pain. 76% of patient come to palliative care services for pain. Major pain type is nociceptive pain, but 30% patient present with neuropathic pain in cancer patient. As therapeutic advancement, it allowed increased survival rate, and due to this increased survival rate, lung cancer and related pain conditions turned into chronic condition. 39% of cancer patient, even after curative intent, are present with some or other type of pain. Under treatment of cancer patient, it not only decrease the quality of life of the patient, but also other symptoms like fatigue, reduced cognition, overall reduced vital capacity, and lastly, this persistent pain lead to spiritual suffering and it limit the patient coping skills also. Pathophysiology already discussed by Dr. Raghu sir that from the local invasion of pain sensitive chest structure as well as consequence of therapeutic and surgery, chemotherapy or radiotherapy, patient come to the pain clinic. So why interventional pain management? International pain management is devoted to use of invasive technique. Why we nowadays use so much invasive technique to treat the pain? Because pharmacological management fail in many of the patients, and it also limiting due to side effect. Advantages is better analgesic outcome without experiencing much drug related side effect. And with the help of technique like sonography, now it is easy to achieve good pain relief with minimum side effect. Common intervention we discuss, and this is intercostal nerve block, paravertebral block, erector spinae plane block, and peripheral nerve injection and interfacial or myofascial blocks. So first come to intercostal nerve block. So intercostal nerve, it arises from the anterior MI of thoracic spinal nerve and provides sensory information from the muscle, parietal pleura, and skin of the anterior and lateral thoracic wall. So any pain affecting this area, intercostal nerve block is helpful in such type of pains. Location of the pain usually begin in the posterior axillary line and radiate anteriorly. So your patient present in your clinic with anterior chest wall pain syndromes or bony pain or constant pain. And pain usually increase with deep inspiration or other chest wall movement. So now come directly to anatomy, sonoanatomy, and probe position in the intercostal nerve block. So in this slide, we can see that probe position should be parallel to the spine, and in this sonoanatomy, sorry, you can see skin, then trapezius, then rhomboid. This is serrator posterior or erector spinae muscle, then rib, pleura. So this is trapezius, this is all muscle plane, this is pleura, this is rib. So main complication in any nerve block around lung is mainly pneumothorax. So you should take care of that. This is intercostal block in my patient. Recently I did. So I want to show in this is external intercostal, innermost intercostal, and this is your pleura. And whenever you will do intercostal block, you always identify this intercostal artery, because it is not easy to find the nerve. But once you can see the artery, like we can see here, the nerve is here and vein is here. So this star is the needle endpoint. गहरी सांस लो, बहुत बढ़िया. So, एक मिनट. So this is in the same patient. गहरी सांस लो. So in this you can see this is shimmering appearance of the pleura. Here is the cephalad, here is the caudal, and this is the rib. So उसको गहरी सांस लेने का क्यों बोल रहे हैं? ताकि हम प्लूरा को फेशियल प्लेन के साथ डिफरेंशिएट कर पाए और हम देख पाए कि ये प्लूरा है. This is again live. In this you can see here. This is your intercostal artery, so that you can identify the intercostal nerve. This is the needle position. So you can see, appreciate the needle. So we are coming from the caudal direction and this is our end point. So you can see this is the tip of the needle. Somewhere here we are supposed to inject the drug for intercostal nerve. And this is again your intercostal artery nerve. This is muscular layer between ribs. This is pleura. It is done at mid-axillary line block. Sorry. Now come to after this intercostal block. Other common block we can perform in USG is erector spiny plane block and paravertebral block. I combine these two because these both are almost same. So injection into the thoracic paravertebral space. What is the advantage? It reach several thoracic nerve root. We are using around 20 to 25 ml in paravertebral space. We can give neurolytic injection in this space if patient is having severe lung cancer or chest wall pain syndrome. So this is the anatomy of the erector spiny plane block as well as paravertebral space. So you can see this is your posterior, this is spinous process, this is paraspinous muscle or erector spiny muscles. This is your innermost intercostal, intercostal and external intercostal, and this is the most important structure, costotransverse ligament, which form the posterior boundary of the erector spiny plane block and anterior boundary of the paravertebral space, and this is the paravertebral space. So we are supposed to inject drug just anterior to the transverse process. So transverse process is the bony landmark. We are supposed to identify if you want to give thoracic paravertebral block. Erector spiny plane block, we are supposed to give here, just below the erector spiny muscle in the fascia. So it is basically a facial plane block. So erector spiny plane is emerging regional anesthesia technique with significant potential of clinical benefit. Exact mechanism is much debated, but according to current literature, this central inhibition from the direct spread of local anesthetic to the paravertebral or epidural space, analgesia mediated by elevated local anesthetic plasma concentration due to systemic absorption. So due to bath of the paravertebral or epidural space, this erector spiny plane block is useful in many of the patients. And what is the second advantage of erector spiny plane block is that it is easy to perform with fewer complication, and paravertebral block is you require little bit skill hand. So it involves injection of local anesthetic or neurolytic agent or steroid immediately lateral where spinal nerve emerged from the intervertebral foramen. Spinal nerve root emerged from the intervertebral foramen and divide into dorsal and ventral rami, and sympathetic chain also lies in the same facial plane. So what is the advantage of this block? It produces unilateral sensory motor as well as sympathetic block. So it is helpful in neuropathic pain also. So this is slide I took from Google. So there are two approaches of the paravertebral block. One is longitudinal approach, where probe is in longitudinal position parallel to the spinous process. Second is transverse approach, where your probe is perpendicular to the spine. So here is the paraspinal muscle. This is a slide for, we can see two transfer process. So this is the longitudinal approach. So probe position is like this. You can see transfer process, and as we discussed that you are supposed to identify this superior costotransverse ligament and inject drug just below the superior costotransverse ligament and above the pleura. So this is transverse process, and this is your superior costotransverse ligament, and this is the space where you are supposed to inject the drug. So it is in my patient. I'm not having very good machine. So, sorry. Scanning. So this is paravertebral block live. So this is muscular layer. Just wait. Here, if you can appreciate, here my needle tip is present. So I'm using 26.1.5 inch needle for doing this block, because usual in normal Linenson patient, depth of pleura is not more than 2 centimeter. Like you can see here, our depth is only 3 centimeter. As this is Philips SD11 machine, so it is little bit shaky. But here you can see this is my needle. This is my needle. This is tip of the needle, and here drug is spreading. Okay. एक second, sir.
You can see that the space was.
So this is needle. So I'm trying to identify the needle tip first, because with paravertebral or erector spiny block, you should supposed to be very cautious when you are doing it, because usual cancer patients are very lean and thin. And here this is the trajectory of the needle, and here you can appreciate the drug spray. You can see this is needle tip. Now you can see this is the trajectory of the needle. So this is paravertebral, as my machine is not good. So this is on Volution E6 machine. I made this video. So we are demonstrating paravertebral block. So we are having Volution E6 machine and demonstrating paravertebral block. This I made only yesterday. In this approach, you can see the probe position. This is the probe position, which is perpendicular to the spine. So this is the transfer position. This is the first approach I'm showing. You can see in this. This is the spinous process. This is spinous process in the midline. Okay. When I go laterally, this is lamina. Above the lamina, it is erector muscle. This curve is the transverse process. When I'm crossing this transverse process, when you cross that, and you can increase the depth, you can see the pleura. This structure is pleura. This is transverse process. This is pleura. This is lamina, and this is spinous process. And in this approach, this is the area where we are supposed to inject the drug from lateral to medial. This is lateral. This is medial. You can see in the patient also. First, this is midline. Then, as I go lateral, then lamina, transverse process, and pleura. So this is the first approach. This is the first approach. Now, so we discuss the first approach of the second approach. Now we discuss second approach of the paravertebral block. In the first approach, my probe was perpendicular. In this approach, my probe was parallel to the spinous process. As you can see the position of the probe. So in this position, you can see in the screen. Okay. So in this approach.
First, it is
First,
midline.
this is the spinous
This is
process.
spinous process.
Once
It is
I
very
go
superficial
laterally,
structure, just around half centimeter from the
then
skin.
lamina, and then
lamina.
above this lamina, this is the transverse process.
This is transverse
Start
process.
appearing.
Transverse
This is the
process
transverse
spiral in
process.
shape.
Okay,
you are
so
not supposed
here
to
we
confuse
can
the
see
rib.
three
It is
layers of
rounded in
muscle.
shape.
One is trapezius, rhomboid, and then erector spiny.
So this is
And
erector
this is
spiny
the
muscle.
area where we
This
are
is the
supposed to
transverse.
inject the drug. You can see
This
in the
is
patient
the
also.
area
My
where
probe
we are
is just
supposed
lateral to spinous process and lamina. Again, you can see when I go more laterally, then this transfer process
It
is
is changed into
disappear
rounded.
and rib is start appearing.
This is rib and
so this is
pleura
the rib.
more prominent here.
So in this we can see this is the rib and pleura is more
This is
clearly
shimmering
visible.
appearance of pleura.
Again, trapezius, rhomboid, and erector spiny. So for erector spiny plane block, we
So
are
this is
supposed
both
to
approach
go
of
below
the-
the erector spiny.
And if you are supposed to inject erector spiny, then you are inject just above the transverse process, just below the erector spiny. So this is erector spiny.
So in this video, we will demonstrate erector spiny plane block. So
It is almost the same. The only difference is
in the
you are supposed to
midline
inject just
with
above
the
the transverse
spinous
process, just below the
So you
erector
can
spiny
see the
in the
spinous
facial
process
plane.
in the midline. Here is the spinous process.
This is
here
the-
is the spinous. Once I go laterally,
Then
like we
lamina,
already discussed, this is lamina. Then lamina change.
transverse
then
process.
transverse
And this is
process
the area
start
where you are
appearing.
supposed to inject
and
the
then-
erector spiny. So now come to the peripheral nerve block. So peripheral nerve block depend on which type of nerve or which type of pain syndrome patient came with you. So it is, I discuss just supraescapular nerve block. So supraescapular gives sensory branch to the acromial, clavicular, glenohumeral, which serves as sensory innervation. Motor part affects supraspinatus and infraspinatus muscle. Blockage of the supraspinatus effective method for providing anesthesia and analgesia of the shoulder. So in lung cancer, usually the structure around the lung is affected more, like shoulder. So patient come with many a time shoulder pain or myofascial pain, myofascial pains or myofascial weakness. So supraescapular nerve help you in such type of patients. So this is again
video. We will demonstrate what is interfacial block.
So
and
you see
peripheral
the
nerve block.
approach
In
position.
this video, we will demonstrate supraescapular nerve block. So as you can see, I start from the midline. So this is the trapezius. This is
This
the
is supraescapular
supraspinatus,
muscle.
and this is the scapular border.
This is scapular.
So once I go laterally, you can see scapular border is
So
dipping,
this is the dip
and
where
here is the
you are supposed to
here
find
you can
supraescapular
see-
artery and nerve and ligament. So here is the ligament and here is the artery. In next video maybe. So this is in my machine again. Okay, just wait. हाँ, हो नहीं रहा था वीडियो. Okay, go ahead. So this is a machine. This is from medial to lateral. As we go medial to lateral, this is your muscle, trapezius. This is supraspinatus, and this is the your scapular border, and just this is the notch. Now I add color, so you can see here. So this is your supraescapular artery. So it confirms that you are in the right place. So this is again block in one of my patient. So here you can see out of plane approach. You can see here needle. You can see the drug spread. Drug spread where you want to spread it. Okay, so 5 to 6 ml volume is very much enough for this block if you are at the right place. So myofascial and interfacial block, especially under USG guidance. So fascia coats nerve as well as vessels, and irritated fascia cause lot of pain, back pain, neck pain, joint inflammation. So ultrasound guided injection has been routinely practiced among patients with myofascial pain. Just this is interfacial block. So this patient was having severe back pain, which even referred to upper limb. As MRI was clear, I give it just myofascial block between trapezius and erector spiny muscle, and patient got really good relief around 50. You can see the needle movement here. This is needle.
This is the trajectory of the needle. And here drug is spread in the fascia. This is my needle is coming. You can see expansion of the fascia. So it is the fascia between this erector spinae and trapezius, which is usually irritated in upper back patient. So conclusion, sorry. So I observed that it is not death or disease which bother the patient more. It is the pain and related suffering for which patient is concerned. And good pain practice by any mean, by intervention or morphine, it is not only improve quality of life, but also decrease recurrence of the cancer. It is good to do early intervention because it is now safe and not having much complication in train hands. And USG is really a boon for cancer patients. It is safe, simple, and effective too. Thank you.
So, thank you, Dr. Avinash. It was a very wonderful, it was very wonderful talk, and the videos were very nice and exclusively made for this masterclass. Thank you once again. So, any queries? We can take the questions.
So, as I'm being very much straightforward in the introduction, but it's really very long. Like once we give, and we are supposed to put the patient on some kind of not medicine. Stretching and physiotherapy. And it's really work.
So, always any myofascial blocks or interfacial blocks, no. Our job is only 30%. The rest of the job is by the physiotherapist. Unless and until you do an extensive stretching, it will not work. Then,
I usually use nervous and if you see that there is a lot of fascia thickening or lot of whiteness between the, then you can create some. Not much. I see that first I will always do diagnostic block. And patient usually respond wonderfully even with steroid. Not very much often. I repeat, every time patient come after 3 months or 4 months or 5 months, that I am having some pain. So first time you put the injection, second time patient demand the injection. You will directly come to you and say, "Doctor, वो injection लगा दो, उससे तो बड़े आराम हो गया." Comfortable.